Good afternoon, ma'am.
Good afternoon, sir.
Yeah, ma'am. Welcome to Shywave, ma'am.
Thank you. Thank you so much.
Ma'am, can you just do one thing, ma'am? Can you just share your screen and flip some of the slides so that we can see that everything is streaming smoothly, ma'am? That is the reason for the trial, ma'am.
Okay. Just 1 second, okay?
Okay. I am stopping my screen share. Screen share and
Okay. Should I share my screen now?
yes, ma'am. You are also going live on YouTube this time, ma'am.
Okay. See, this is fine. Are you able to see
Yes,
my
ma'am.
screen?
That is fine. Yes, ma'am. Shall I
Yeah.
send you a screenshot, ma'am? How does it look like?
Yeah, please. Thank you.
Okay, ma'am. 1 second.
Should I keep my video on during the presentation?
Ma'am, as you wish, ma'am.
Okay, because suppose sometimes, the stream is not very the range is not very good. So if the video is on continuously, then sometimes there'll be audio issues, if at all. So maybe I'll keep switching off and on in between,
Okay, ma'am.
like that. And you give me, I have my mobile, to the side. So if I'm not clear or you're not able to hear me, then you just message me anytime.
Okay, ma'am.
Yeah.
Ma'am, I'm sending you a screenshot. It looks perfectly fine. Because, ma'am, you are now not in like with your video on, ma'am. That is why that has got shifted, ma'am. Otherwise, it is fine, ma'am.
Okay. Yeah, so I think I'll keep my video off only then, you know. That
If
is
you want,
better.
ma'am, you can also keep it. Whatever is.
Okay, so how is it seen with the video on? My photo will come to the side, is it? Uh, Can you send me one screenshot of me video with video on? Hello?
Hello, am I audible?
Yes, audible.
Welcome, ma'am. If we are ready, then we can start within 5 minutes. Please all
Sure.
join.
Shalini ma'am, I think time is almost approaching, so you can carry on with your introductory speech and then go
Okay,
ahead.
okay, sir. Okay, good afternoon to all of you. I'm Shalini. Welcome to the second presentation of ISLP Special Interest Group 2023, an initiative of SHI-WB. I think Prakash sir is having some problem with the sound issues. Uh, am I audible?
Yes, you're
Yes,
audible.
you are. Yes, you are audible. I am answering to Prakash's question. You can carry forward.
Okay. So we are here today for the presentation, second presentation of ISLP Special Interest Group 2023, an initiative of SHI-WB. Firstly, I would like to Mr. Prakash Kumar, the MD of the company Auditivo, to have a few words with us. Mr. Prakash Kumar, sir, are you there? Am I audible to you? Hello? Mr. Prakash Kumar, sir, am I audible to you? I would like to ask you, sir, to have a few words about the Auditivo Mic Company.
Shalini,
Yes, sir.
there is a problem with network connection. Probably, I have already called Prakash Kumar ji, so he
Okay,
will
sir.
be joining within 2-3 minutes.
Okay. So, sir, shall we wait then for some few more minutes?
Just wait for 2-3 minutes.
Okay, sir. Okay. Okay. Thank you.
Shalini ma'am, Prakash sir is in now. So he
Okay,
had
sir.
some technical issues which he had resolved. Now sir is there, can hear us. You can just carry on with your introductory speech again.
Okay, thank you, sir. So I wish you a very good afternoon to everyone present today. Welcome to you to the second presentation of ISLP Special Interest Group 2023, which has been an initiative of SHI-WB. I would like to ask Mr. Prakash Kumar sir, the MD of the company, to have a few words about the Auditivo Micro Company. Over to you, sir. Thank you. Mr. Prakash Kumar sir, am I audible to you? I think sir is having some technical issues.
Hello.
Yes, sir.
Yeah, am I audible to you?
Yes, sir. You're audible.
Yeah, sorry,
Good.
sorry for the trouble. Yeah, my name is Prakash Kumar. I'm the Director of Auditivo Hearing Services Private Limited. And thank you for West Bengal Isha organization to organizing this wonderful webinar on this subject for CSL. And we also thank you, Madam Namita, Madam, for accepting our invitation to just speak on this subject, Madam.
Thank
And,
you, sir. Thank you.
Actually, auditivo hearing is always able to do something for your organization, and will keep on doing it. And thank you all for joining us.
Thank you, sir, for sharing your time and sharing your views. Next, I would like to introduce Dr. Namita Joshi, ma'am. She is currently the director of Sampark E-Polyclinic Pune, Kothurud and Katraj branch. She has a clinical experience of 19 years and been teaching for graduate and postgraduate degree courses for 15 years. Ma'am has done 24 conference presentations and 12 article publications and guided for 12 dissertations. Ma'am has recently published the first ever Marathi book on voice culture for vocal performers. She has been reviewer of PhD thesis and has also been doing official training to use CSL by Pentax Medical. Ma'am is the EC member of ISHA and has been invited for many TV, radio, and talk shows on voice culture. We are very fortunate, ma'am, to have you amongst us today. Thank you, ma'am.
Thank you. Thank you so much.
Over to you, ma'am. You can start
Okay.
the presentation now.
All right. I'll share my screen now. Is it visible?
Yes, ma'am, it's visible.
Okay. Good afternoon, everyone, and thank you so much for inviting me. I thank West Bengal chapter of Speech and Hearing Association of India for calling me here for this topic, and I'm very glad because this topic is very close to my heart. I've been practicing in speech and hearing last 20 years now, and acoustics of speech is one of my favorite topics right from the student days, and that was because of the late Dr. Savitri, and I really, I hope I am able, like people are able to hear me. Am I audible? Just give me thumbs up.
Yes, ma'am,
Yes,
audible.
ma'am. You are audible and we can see you, ma'am.
Yeah. And the presentation is also clear?
Absolutely, ma'am.
Okay. So and thank you, Shalini, for such a wonderful introduction. And let us begin with computerized speech lab, clinical utility for private practice. So what do we expect from today's presentation is the overview of CSL software and its use, how to use that software, because I don't know how many of you have used it. If you can just raise thumb if all of you have used the software at least once or twice, or you have it in your setups. Can you raise the thumb? Or just say yes in the chat, or maybe how many of you are using this computerized speech lab software in the institutes or in the clinical practice? You can just show me the thumbs up. Yeah, I think 4 or 5 of you have showed. Yeah. Okay. So out of 26, I'm getting only 8 people who have used it. So I'm sure that, today's presentation is going to be helpful for the others who have joined. Utility of CSL for voice and speech disorders, it is what we are going to look at today. And software-based discussions, like if you have any doubts, like which parameter to use for particularly which disorder, we could have that. And benefits of using instruments in clinical practice or private practice is what we are looking at. So why do we need computer speech lab in our private practice? Okay, that is what you're going to learn today. So why do we need instruments in private practice? This is my first slide. So if you see at the right side of my slide, you will see that there is one graph which shows like the old method of coloring the particular level of IQ, and the second graph which shows a computerized IQ test course. So which one do you think is more attractive? I'm sure the one with more visuals and graphs and measures where they are computerized, calculated, is more attractive for a person who is coming to get something measured or coming to get something treated from a doctor. So I'm not saying that the old methods were wrong, definitely not. But as the digital era is begun, and since the millennial, everybody is on computer, and the Gen Z is more onto the softwares and instruments. I think it is for the clinical practice also, it's time for us to get a little bit digital and getting it better, and doing the perceptual analysis as a gold standard is definitely not going anywhere. So using instrument doesn't mean that we have to leave the perceptual analysis, but using the instrument is for systematicity. Using instrument is for accuracy, consistency, visual format display. It's better in instrumentation. Perceptual correlation comes better. You can convince the patients that yes, your voice is improving or your voice is not improving, so you need the surgery or whatever. So therapeutic measurements like pre and post surgical comparisons. And of course, for a clinical practice, you need a lot of database of your own, and scientific reporting is also equally important as you clinically practice. But I'm sure that many of us in India who are in private practice are not doing this database recording and scientific reporting on day-to-day basis, where we don't use softwares. There's so much to write and so much to record on paper if you do not have these instruments for your help. So I'm sure you all agree with this. So definitely we are looking at instruments, but we are not forgetting our base, our gold standard perceptual evaluation. Okay. So can we not do without the instruments? Yes, we definitely can. Perceptual evaluation is the best with experience. However, instruments can help us bring more objectivity to it. So, for example, like a person who has 5 years of experience versus a person who has more than 30 years of experience, definitely the assessment will vary, because it goes, the better your ears are, the better the experience your ears are, you definitely can identify the smaller features in the voice perceptually better. So with addition of instrumentation to your clinical practice, we are not leaving our base of perceptual parameters, but we could get that whatever quality of assessment and treatment little earlier. Like suppose say I'm a 5-year-old experienced person in the field, with the instruments and pre and post qualitative assessment and quantitative assessment, I could go little further. My analysis can enhance little further, like a 10-year experienced person. Definitely, it will definitely add on to your analysis and judgments. So correlation of perceptual and acoustic parameters to be brought into daily practice, because we just hear the voice, rate the voice, do our perceptual assessments, questionnaires, patient rating scales, and we sometimes do use Pratt, which are free downloadable softwares. But there are many, restrictions on the recording device, the recording sampling frequency, the clarity of the recorded samples for analysis. I'm sure that the time when we used to use Pratt or free downloadable softwares, the compared to those days, now the quality of Pratt is much better, and there are many more additional features added on to it. But a systematic norm-based software will always be more accurate than any general recording sampling device. Okay, so professional devices which are used in these studios of singers and actors, that kind of system is included in computerized speech lab, which is more reliable than the general free downloadable softwares. So if you want to be more accurate, if there are many studies which have compared CSL versus Wagmi versus Pratt, there are many studies, there are many research articles on it. So they have come to the conclusion where when it comes to connected speech sample, the results are variable, but when it comes to phonation sample, the results are pretty much the same. Many studies have not correlated it with the perceptual analysis, but many studies have just compared over phone recording versus computer recording, the two software comparison. But today I'm not going in those details because I'm here to talk about computerized speech lab. Model 4500 is the one which I have used the most, and this is what I have learned from my experience of CSL. I used it around 12 years, and that is the experience I'm going to share with you. So though you've called me as an expert in this field, but my experience with CSL is 12 years, and I have been doing voice and speech disorders. I've been using it, and I find it very useful for clinical as well as database. And moreover, as a private practitioner, I was in the institute for around 14 years, and when I came to private practice, the whole scenario of looking at the patient or the patient looking at me changed. When it is a hospital setup, you don't really have that kind of presentability. I'm not saying the institute people are not presentable, but there is some ethic or sense of ethnic value to the private practice. If you're sitting in a particular cabin on a table versus giving a computerized report, that particular impression is much better in private practice, and it does matter, is what is my experience, especially in cases with voice. Okay, so this is what I feel. So this is how the computerized speech lab looks. Okay, and this is the preamplifier, which has professional grade audio capturing device, okay, which is calibrated input for real world amplitude measures. So it is a live recording also is very much possible. Superior signal to noise performance is possible. It's a reliable service and technical support. 2 to 4 line input channels, DC coupling for low frequency signals, okay, like EGG. So all that is built in this particular small device, which is shown on the graph. So what does Pentax Medical has to offer to us? It has many programs and many softwares, but today we are going to talk about only these 6 softwares, because I've been given only 1 hour to talk to. And so I want to focus on speech and voice disorders per se today. So analysis of dysphonia in speech and voice, ADSV software, we are going to talk about it. We're going to talk about MDVP. We are going to talk about motor speech profile. We're going to talk about real-time pitch, and we are going to talk about auditory feedback tool. Okay. So other devices we are not going to cover today. 6 major devices which are used for voice and speech disorders, we are going to use it. Okay. So moving on to the first parameter or first software in CSL, that is multi-dimensional voice profile, MDVP. So this is how the window looks. Okay, when you open MDVP, this is how it looks. So it has a parameter window A, parameter window B and C. And then you get analysis of different parameters of voice of any pathology with a single vocalization. So you have to record a phonation sample and you can see the recording with different toolbars. So this is how you record. To begin a recording, select the red color circle on the toolbar. Then you record the vowel and then you play back the signal to make sure that the signal was recorded properly. And then you see once the recording is done, you play the all button on the menu bar to complete the MDVP analysis. And this is how the circle will come. Okay. Actually, we were supposed to have the live demo of the software today. Unfortunately, we couldn't arrange that. Otherwise, this would have become very, very interesting. But never mind. I have played some screenshots to you so that you can see how it actually looks step by step like a video. So in window G, you can see that there is MDVP analysis for 4 parameters, that is relative average perturbation, voice tremor index, noise to harmonic ratio, and shimmer absolute. So these parameters could be changed according to your convenience. This is a VisiPitch multidimensional software where you can go to the MDVP report setup and you could select the parameters you want to see. Otherwise, in the whole analysis, you can see all the parameters anyways. So you can select, you can change the gender, you can fill in the required in like the data of institution name, address, diagnosis, comments. You could write about a little bit about history of the patient, and everything you can get as a printout. You can also here, before diagnosing or before commenting, you also get these macros, that is the pre-recorded samples of different voice patients. You can see that hoarseness, soft phonation, F naught variation, F naught change, super high F naught, and breathy voice. All the macros are given to you in the software. So when you play one of the macros to just make sure that whatever you're diagnosing about this particular patient is right, you can hear it, you can feel, you can see how the graph looks. All values are outside the normal range. The red has come, the green circle is shrink, and then RAP, shimmer are way out of the normal value, and that is the voice turbulence index is slightly up, and HR is also slightly up. So this is like how the voice with hoarse voice will look on the graph. Okay, so you can go to the report analysis after this. Once you get this graph, you can go to the report, the sign on the menu bar, and you get these parameters and the normative value according to the gender. Okay, so this is how a MDVP report is getting completed for a patient. So now moving on to, many people ask me like, okay, this graph does not tell us about pathology. Yes, it definitely does not tell you about the pathology, because the particular graph cannot tell whether it is a polyp or a nodule or a say phonatory gap or sulcus vocalis or breathiness due to the vocal fold paralysis. It does not tell you that. It tells you about the qualitative analysis of voice, where there is a pitch perturbation, or where there is a intensity perturbation, or where there is a noise parameters which are affected. So how do you come to the conclusion whether it is a nodule or a polyp? You have to take another instrumental analysis, which is called endoscopy. And you also can, with the experience, you can feel that, okay, this is a mass lesion versus no mass lesion. Okay, you can say that kind of comparative with experience. But when you are using it for the first time, you rely it on your perceptual analysis. You get correlation with the perceptual analysis, and then you say whether it is breathiness, hoarseness, or relatively harshness, or a noise. There is noise more, so a little bit of harshness. So you say that, and you don't say whether it is a nodule or a polyp, depending on the MDVP analysis alone. Okay. So this particular graph, which is shown, is given by a study where you can see it was a single token recording where they had sustained phonation vowel recorded. And you can see that pre versus post. Okay. So A condition is a pre condition and B condition is a post condition. So they had recorded the voice pre and post, and you can see that the green circle increased, the red portion shrink inside the green circle. That means there is betterment in most of the qualitative, that is degree of subharmonics, these parameters, degree of subharmonics, degree of voice breaks, the tremors, the frequency of tremor, amplitude of tremor, soft phonation index, voice tremor index, all these parameters are now reduced. So what do you see here in the vocal nodule case? There is SPI, which is more, and there is pitch variation, which is more. So with the experience, you will see that when there is more of breathiness and not hoarseness, you will see more of tremor index, more of degree of subharmonics and degree of voice breaks than the pitch parameters. So noise and the intensity parameters will be more affected along with the SPI. With mass lesion, more of a pitch is supposed to be affected than the intensity ones. So with the experience, you will know and you will understand that this might be a mass lesion or this might not be a mass lesion, depending on the experience. Moving on to the second case, this is post-thyroidectomy, definitely a unilateral vocal fold palsy case. So you can see here that more of a intensity parameters were affected along with the pitch, and the circle is not as shrunk as it was in the mass lesion. Okay. So there is voice which is coming out, but it is not as shrunk as it was before. And when you say post-treatment, only the amplitude parameters remain outside the circle. So why does the amplitude parameter remain? Because definitely, even though the vocal fold paralysis might have improved, it cannot reduce the air coming out or air escape completely from the patient. So there will be some amplitude perturbation quotients remaining post-treatment as well, sometimes in the cases with unilateral palsy. So this is how you have to, gain different experience with using of this software. So clinical utility of the MDVP software, what is it? Pitch and perturbation measures, definitely we are getting intensity, amplitude, perturbation measures we are getting a good visual display of these parameters, and we can correlate each parameter with the quality or the pathology. So endoscopic evaluation, most of the places where you are doing your clinical practice, probably a otolaryngologist has sent an endoscopy video to you with the patient that, okay, this is what is the problem and you are supposed to treat. So first time when the patient comes to you and you show him that, see, the red circles are more and I'm going to make it green for you, don't worry, that makes a lot of impact. And I usually keep my patients videos also, so that when they have pre and post data, then they see that some patients where the vocal nodule disappeared just by therapy and they did not require surgery, the patients are really surprised and they start believing in what you tell them to do. The exercises are done properly, the patients are following the routine properly, and the results are then gained. So the visual display to the patients matters a lot in terms of voice, I would say, as per my experience. Parameter with normative data is very good, and as some people might have known that now the CSL India has incorporated the Indian standards as well, and there were many studies in 2007 and 9 and 2020 that doing different softwares normative for their own country or the state. So if you feel that generally in compared to Western countries, we have like Indian versus American, we have more of a jitter and shimmer are higher than as compared to the normative given in the particular software. So you could have some parameters which are away or out of the normatives for your own region, depending on the height and the general body mass index. So depending on that, you could have your own normative measured. It's not for all parameters, I would say, as per my experience. Just jitter and shimmer usually are literally little higher. which are not literally or eventually not lower than 3% as it is given in the manual, but you could have that relative a particular normative for your own clinic, but that is not difficult at all. Like you could measure it with 30 cases and make sure that, okay, this is the range it is going, standard deviation plus minus this much it is going. So normative data are available all over the places now. I'm sure even the West Bengal branch has done something at AYJ. So used for clients with voice pathology, this MDVP software is usually used with a sustained phonation. It is not supposed to be used with connected speech. Okay. So in MDVP, we cannot do the analysis for connected speech. It is mainly for the sustained phonation. So when the patient has a really severe voice issue and the patient is not able to even phonate for particular seconds, then MDVP becomes a little difficult. So we do have to take help of a different software in the same CSL, some computerized speech lab. But MDVP sometimes has restricted access to the patient with very severe voice and the patient who is not having maximum phonation duration of say more than 4 seconds. So it becomes difficult to capture if the data is lesser than 4 seconds. So sometimes it so happens, but otherwise for the sustained phonation, MDVP works the best. So voice quality versus vocal fold pathology cannot be pinpointed. So if you have hoarseness, you cannot say it's a nodule or a polyp, okay? So we can just say it's a hoarseness depending on MDVP. So this is the clinical utility for MDVP. I hope I'm clear. If you have any questions related MDVP, you can put it in chat box. So moving on to ADSV, that is analysis of dysphonia of speech and voice. So as the name indicates itself, we can now do the connected speech analysis much better way than the MDVP here, okay? So this is how the window looks when you open ADSV program in the CSL. This is how it looks. So used for analysis, fundamental frequency, as it uses Kepstrel analysis to determine F0 irrespective of time. So here, even if the sample is little lesser, you could do the analysis of F0, and if with the severe phonation or dysphonic voice, we could definitely get a good amount of analysis here in the running speech, in the running text. Okay, so abstract the F0 for both running speech normal and dysphonic speech. And this is how the first window looks, where you have A, B, C, D windows to give different parameters. Your A window is the sustained waveform, where you can record the sustained vowel. So the protocol says you can have different samples recorded. So you can take a sustained vowel phonation, you can take easy onset sentence, you can take all voice sentence, you can take hard glottal attack sentence. So the 6 sentences basically used in Cape V. You all remember the sentences like you were here a year ago, we were here a year ago, something like that, those sentences. So those sentences are used here, and also you can have a rainbow passage. So when you select a protocol, you get a particular instruction to what to do and what to record, okay? So you can record it for 3 to 5 seconds, say, this is how it looks after recording, okay? You can see the recording again, whether it is, you can stop the recording, hear the recording, whether it is appropriate, and go for the analysis purpose. So analysis purpose, you have to go on the, again, menu bar, select A, and then automatic data selection can happen with the blue bar. If you think that the data was not really good whole over the window, you can select the specific data from the window and you can do it. So analysis is performed. Window A gives usually the source waveform, which you have recorded, a lower and higher ratio of the Kepstrel peak prominence C, and window D gives you spectrograph. Window B gives you spectral analysis, and window C gives you Kepstrel analysis. Okay, so this is how the ADSV program looks after the analysis is complete. So once it is completed, you can have the print solution, you can have the calculate or give me summary or give me the report solution where you get the values and you can save it and print it. So most important value here is CSID, that is Kepstrel Spectral Index of Dysphonia, okay, which includes variety of parameters and plugs them into a formula of regression analysis and gives a single number, which is from 1 to 100, and 0 is supposed to be most normal and 100 is supposed to be the dysphonic. So more the value of CSID, more is the dysphonia. That is how it is look like. It looks like. And CPP, that is capsular peak prominence, it is just the opposite. Higher the value of capsular peak prominence, better is the voice quality. Okay, these two parameters can also be used for other than dysphonic speech. You can also use it in cases of dysarthria, where you can measure the intelligibility in terms. Higher the value of CSID, lesser is the intelligibility, and vice versa, because it's a connected speech as well. So you can correlate with intelligibility of speech very, very beautifully for your scientific reporting. Then next protocol, you can take a rainbow passage, go to the new live input. You will get a passage to read in the window itself. So you don't have to have any paper sheet, nothing. The passage is read in front of the eyes. And definitely you can ask the person who is able to read, you can take this sample, which is more standardized, or you could also take this the 6 sentences said by the patient or copied by the patient. Okay, if the patient is not able to read, you can just ask the patient to say those sentences after you, and you can record. Again, the same analysis happens, and you can get all the analysis performed. You can get energy versus frequency graph. You can get septal and capsular energy versus time graph. You can get low to high ratio of the energy. You can get capsular peak prominence, everything in the one go. Okay. So this is how the analysis will look for a different sample. So if you have taken a sentence sample, then it will give you a different norms and different parameters. If you have taken a rainbow sample, it will give. So for each sample separately, the values will be given. So it is very, very good to analyze sustained vowel and a connected speech sample here as well, because it gives you both. You can record a sustained vowel as well as the connected speech and compare it. So initially, when you treat voice patients, you will see improvement in sustained vowel, but the sentence level won't be as good. So you can actually show that to the patient, like, see, now with only 2 sessions, your vowel parts are coming better. You can get more higher, like lesser value in CSID, higher value in CPP, your spectral energy is increasing. And that is the good sign that vowels have started coming slowly. Then it will come to nasal, then it will come to the other non-nasal consonants. So definitely we are not recording here all nasals, but we can show that the hard glottal attacks have reduced. We can show that the all voiced sentences, it is better now. So you can show all, like, voicing is happening better. Initially with vocal fold open or escape of air, voicing was not happening better. So all this discussion can happen with the patient with the screen on, where the patient feels that yes, you are doing a scientific data, you are doing it very properly. So all this, we do it in a perceptual evaluation and a normal therapy as well. Okay, but it is very, very difficult to make the patient understand what smallest change your voice is showing today after 2 sessions, which was not there earlier. So these parameters and the graphic and visuals in the software give us very, very easy tools to explain to the patient. And patients who I'll tell you, I've had patients who are engineers from army personnel, and they really love it. They understand the data better, they understand your techniques better. So why am I giving SOVT technique to a patient, or why am I giving any vocal fold closure exercises? It is so very nice to explain this to patient depending on this data. So select the help option if you have any additional question related to the software. The software gives you help option, and the manual on how to interpret each and every particular parameter in it is also given in the software program. So measuring connected speech, we can definitely diagnose severity of dysphonia, and also, as I told you, intelligibility. So there were studies, Ishikawa and Peterson et al. In 2017 and 21, they had done the correlation of intensity of severity versus the intelligibility of speech. As you can see in the left window, the patient was more, because the CPP was much higher, you can see that there was much better voice or much better intelligibility versus where the CPP was lower. Okay, so that is how the data are correlated, and the patients can be shown that the values is higher versus values is lower. So the particular one, the clinical utility of ADSV, the ideal for dysphonic voice samples, because in some severe cases, MDVP cannot identify, cannot record the sample as well as ADSV, because it is irrespective of the frequency versus time graph. So it also sometimes in the regression equations can take away the gender as a parameter. So you can get in connected speech irrespective of gender. F0 analysis is very easy and can be correlated better with the perceptual analysis, because the sentences given in CSID is the KP sentences which are phonetically balanced. So it is best correlated with KP, that is perceptual analysis. The studies have shown that if you take a CSID parameter versus a jitter shimmer parameter from NDVP, the jitter shimmer parameter or any parameter which are perturbation parameters, whether it's frequency or amplitude or noise, like noise to harmonic ratio or degree of subharmonics or soft condition index for that matter, did not correlate as well to the perceptual parameters as CSID has correlated and CPP has correlated. So the parameters which best correlate with the perceptual analysis is in ADSV, where the data is not cohesive. In particular research in voice cases, what happens is when we say mild, there are so many varieties of mild, So in GRBS or in any KP particular parameter, the mild variation itself is so very much that the data sometimes does not just correlate in studies where you have sample size less, especially in dissertations. So if you are doing such dissertations, you can do CSID parameter, which correlates better. And also it can be correlated with intelligibility of speech in cases with motor speech disorders. Okay. So I hope I'm clear so far with ADSV. And if you have any doubts for this, you can put it in chat box, and we are going to take the doubts, question answers at the end of the presentation. Moving on to the next parameter of CSL, that is motor speech profile. So everybody knows that this particular parameter is used for the patients with dysarthria. And this particular software is used for patients who have motor speech problems. So it measures acoustic parameters associated with motor speech disorders, and it has given a straight protocol where you have diadochokinetic rate, we have second formant transition, voice and tremor indexes, intonation stimulability, standard syllabic rate. All these protocols have been given, and you can get one protocol. You can select different protocols and take a live input of DDK, for example, and the instructions are clearly given on the screen, what you need to do and how. And also there is a sample given. So if the patient does not understand you because it's a motor speech disorder, then patient can see how it is said. So you can actually play this sample. So this is a sample given by the software where it says papa 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 continuously, and the patient can hear it and see how it has to be done. Okay. And then you get a capture window for the live input of the patient. So this is how you record for your own patient, change the gender, and this is the graph which you get. The green is the normative data, the green values, the dark green value is the recording, and the yellow is the standard deviation. So as you can see that this average DDK period is 168 milliseconds. The norm is 168 and standard deviation is 14. So this particular patient who has recorded this is within the normal limit. So this is how we get. So click on the toolbar to generate the report, and this is how the report will look, and you can print the report on the letterhead, or you can get the software also customized for the report format. Another protocol is standard syllabic rate. So again, the read the sentence. So we knew you were away all year. This is one of the sentences from KP. So you could record this sentence and again get the values of diadochokinetic rate, and then the diadochokinetic rate and the standard syllabic rate, both the data will come at the one click for both the patients. Okay. So you see, as you can see, the diadochokinetic rate protocol for the same patient and the standard syllabic rate protocol for the same patient is coming in one line, and you could get this print also. You can have it in the print format also to give it to the patient. Okay. So this is how it will look. So average syllabic rate is 4.7. Normal is 5.11 with a standard deviation of 0.4. Okay. So this is how you could also change the colors of the setup if you want, like diadochokinetic rate in yellow and green. For standard syllabic rate, you can have the change of color so that the patient doesn't get confused. And then you can also add an select for which you want the normative diagram, for which you don't want. You can have the customization of your protocol. And then print the report or save the report online and send it online to the patient as well. So this is very easy. It becomes very easy. It gets saved as a Word doc or a PDF, whatever you want, and you could just send it online as well. So easy, like the clinical utility of motor speech is easy to measure protocols of motor speech disorders. You can use it for stroke patient, Parkinson's disease, dysarthria, etc. Visual display of parameters for comparison is very, very easy here. Diadochokinetic rate versus standard syllabic rate should be practiced. We do it perceptually, isn't it? Everything is in our mind, but we do not have the habit of recording it while the patient comes. So when the patient comes, this takes absolutely 2 minutes to compute the whole report. Okay. So from the patient sitting to your window, like chair, and you recording and actually doing the report, it takes just 2 to 3 minutes. It doesn't take more. So it's very fast and quick, better than you taking the notes with the hand of the paper and then recording the signal, analyzing the signal later after the patient is gone, and then making notes. It takes time, versus we as a private practitioners, I'm sure who are attending the seminar would agree to me that we don't have time, isn't it? We have so much less time to do all this. So let us be, we should gear up about doing this in a practice of daily routine, because record is saved. It's paperless. You can just send it to the patient on WhatsApp. Database for different motor speech disorders can be generated. Report writing becomes more objective and can be correlated with perceptual measures very, very easily. Okay, because ADSV and motor speech profiles can be correlated with perceptual rating scales. That is how the research has shown that it is the best correlated with research of perceptual analysis. So moving on to the AFT software. Okay. So AFT, this is how the first window looks, and it is majorly used for persons with stuttering. So people who have the data, like patients coming off voice, patients coming dysarthria or motor neuron disorders, or patients with stuttering, definitely AFT is used. So you get a metronome built. You could change the speed, pacer, and the beats are heard on the speaker or the headphones, whatever is connected. You can start and stop the button. There is also delayed auditory feedback to start and have the delay. You can have the delay and heard, the patient can hear it in the headphones. You can have the delayed auditory feedback from 150 to 500 milliseconds. You can have looping, which is, the next one, the amount of time it can be recorded is 5 to 30, and you can keep having the loop. So for some dysarthria patients and even the patients with stuttering, the closed loop technique is used. So this is very good for that. And the next one is time wrapping, which is again the wrapping factor is 30 to 300, which is very, very nice. And the wrapping factor below 100 will play the recording faster than the original one, and above 100 will play the sample slower. So you can have this particular technique used for dysarthria as well as some of the patients with stuttering. Masking is used, so you get a frequency bandwidth, noise which is coming from the headphone, and you can mask your speech and use it for patients with stuttering. The last one is the recorded data length. You can change this recorded data length depending on how much, what task you're doing, whether you're doing the connected speech versus just the syllables or the words. You could change this. Again, for the further queries, you get a help button at the end to find out. But this particular software, AFT clinical utility, is used for fluency disorders, client with motor speech disorders. It is easy to use, but no recording is saved and no data is procured here. So you don't get any value here. You don't get any report here. So therapeutic tool baseline needs to be set with the clinical yardstick. So it is up to your experience, like how much should be the beats per minute kept for the moderate level of stuttering or minimal level of stuttering. That knowledge you should have, because the software doesn't give you any yardstick. So the experience and the knowledge of the clinician is very, very crucial to use this AFT tool in the CSL software. So again, if you have any doubts about this, you can just put it in the software. So iKP is the online version of KP, which is very, very beautifully done. This is how the window, as soon as you click on IKP button in the CSL, it looks. A perceptual evaluation, which is developed by Asha, KP, everybody knows that, which is done online, okay, electronically. And it has addition of previously and name by clicking pull down menu, you can gain the new clinician. Like you could add the clinicians, you could add the patients with the select new option. Then put the clinician name, say okay. Okay, and then you get this window. Then you add the details of clinician as well as the patients. Okay, and say the new client, new valuation. And then you get, can you switch the microphones, please? Please switch off the microphones, others. Yeah, thank you. So this is how the window is seen of IKP, where you have sustained vowel recording, sustained phonation, or all vowel, easy onset, all voice, all the sentences. The sentences are also written. That's the blue spot is on the sky again. How hard did he hit him? You know, all these sentences. And then you have to record, read the ASHA instructions before you carry out this test. The ASHA instructions also given here. So read it, how to record and how to say. Okay, and then start recording the sustained vowel. Say, for example, sustained vowel protocol. If you choose new live input, it will give you the instruction what to do. You record live and save the button. Select the area of selection. So the saving does not happen with the file menu here, like usually how we save it in the file menu and then save. It has a save, auto save selected signal option here. Okay, so we don't have to do it by the regular save option. We have this A save option here on the bar menu of the IKP. So select the area which you have to save as audio file and you can set A. You can just click A on this particular bar. And then it gives you file has been saved and then IKP analysis can be started. So you record it, then play on the audio signal. Like you can now see that sustained vowel recording is being saved and you can now hear it, listen to the sample and start recording it. So you can move this particular cursors or dialog boxes on overall severity, roughness. You can move it with the cursor and put the scoring. It will give you total automatically, objectively when you move the cursor, and you can ultimately showing both values 1 and 2C. Like you can have all vowels, all voice. You can have different samples recorded, and you can have different KP scores depending on the what sample was. And then you say that yes, you wish to modify. You can modify if you have any changes. And this is how it is set. So IKP, there is not much to discuss clinically. Everybody knows it's a perceptual evaluation. So it gives us the visual, very easy to do calculations. We don't have to use the visual analog scale, measure it, and then record it, and then do. It is electronically calculated very easily. And these sound files also gets automatically stored when you record this. So you have pre-data and post-data audio files and perceptual evaluation at the same time. And you could give the VHI or any client-based rating. If you are doing perceptually, then you can give it to the client. And you can have this for a record on yourself. Okay. So this is very, very good. Clinically, the data is saved on the patient name. And you are, not hassled ki, okay, I had done this KP, where did it go? If the patient loses the file or you lose the file, then it's not a problem. Like in this particular software, it is all saved with the audio file with the date on. So you also know which date you recorded this and which and particular like the sample you did this KP. So you have different KPs for connected speech versus the sustained phonation. Usually we don't do sample wise, isn't it, in clinical practice? Like we are that lazy, like okay, we just do sustained phonation, running speech karna hai, abhi time hai, all that we see and we do. But in here it is so easy and it gets done in 5 minutes. So you could do that. So next is real-time pitch. Again, this particular software is used for tracking the vocal pitch or fundamental frequency and as well as loudness. So very, very good for using it for singers, professional voice users, also for stuttering, also for children with hearing impairment, for children and adults with hearing impairment, children and adults with dysarthria. A wonderful, wonderful software where you could give a sample. Okay, left buttons are there on the menu bar. When you want to record, you can pull it down Window A is given and window B is given for the comparison. Load or create or target signal in one window, record speaker signal in another window for comparison. And that is how you can also do the pre-post comparison by saving these signals to your file. So it's wonderfully shown to the patient as well. So you can retrieve window A pre and you can record window B live, and you can show how different your voice is today or how different your pronunciation is today, depending on which patient are you talking. So this is how it looks for the recording of one sample. Frequency over time is like frequency here is blue and energy is gray. So you can show that, okay, this is your pitch, this is your intensity at this point of time. It is also very useful for cases with puberphonia, androphonia. You could show them and you get these particular values. You can select the parameters which you want, pitch wise, energy wise, and then you could also have targets to reach so that the patient can copy you. And it is very wonderfully used. So this is how statistics button will give you the statistics as well. So you could get the live recording and the analysis then and there. So you in here, if you observe, you're also getting semitone range, semitones for singers, especially. It is very, very useful for the singers if you tell them about their semitone range. Okay, don't go beyond this range or don't go below this range for the lower pitches. It is wonderfully used for the professional voice. Okay. So this is how the RTP setup looks. Biofeedback and assessment tools can also be used. So you can give the feedback when you set up the targets. Selecting the assessment protocol for habitual pitch, and then you get these windows up and you get the normal voice. Click on OK, count to 10 in normal voice. So what needs to be recorded also is given on the screen. So you don't have to think, okay, what I need to do next. Once you select the protocol, it already tells you about can you ma'am please switch off the mic? Yeah. So this is the recording of the sample. Okay, so you got the values. After ending the recording, following values will be displayed to save it for the future. You can also change the colors of the contours in RTP setup. You can also get maximum phonation time here, pitch range. Okay, so you have different setups which you can use here. Okay, maximum phonation time, pitch range, all these setups can be used. You can tell the patient to do it and give the visual feedback as well. So am I clear so far? Okay, this is the maximum phonation recording. I'm not going into detail. Everybody knows how do we do. Okay, so again, this particular parameter, the clinical utility is very, very clear, and it is more useful. It's a more therapeutic tool than the assessment one. So we have now moving on to the first was MDVP, second was ADSV, third was motor speech profile, which were more analysis tools. And we have come, the fourth one is AFT, which was therapy. Again, the real-time pitch, again, is the therapeutic tool. And voice games is the last tool of today, again, is the therapeutic tool. So I have taken 3 assessment tools and 3 therapeutic tools for today's presentation. So moving on to the voice games, much fun. Everybody probably have seen this, like different therapy games where you have visual feedback for the test associated with the pitch, amplitude, and time control of the voice. This is majorly for voice. First row of the game has phonation duration and amplitude. Only phonation duration. The first row, the monkey, frog, and the one is having the phonation. The second and third row have fundamental frequency and amplitude control as well. So as you see, we have set the fundamental frequency particular range. And if you set the range, the display will show you the range. And when you start phonating, by playing the start button, you can select the intermediate level or beginner level or balloon sound, how many balloons you want to be displayed, and maximum phonation fundamental frequency 150 to 450. And as you start phonating, the dragons start emitting the fire and firing the balloons, and one balloon is bursted. So for amplitude, similarly, you can say the speed, how much, number of fishes, how much, and display of the fish, how much you want, minimum target range, maximum target range. And as you go on phonating, the fish is going up and down depending on the right hand side, you can see the degree, like in terms of amplitude, 50 to 90 dB, and the fish go up and down, okay, accordingly. So this is how, these are how, there are many games here. So what is the take home message for today? CSL, we have seen multi-dimensional voice profile. We have seen ADSV, that is analysis of dysphonia of speech and voice. For multi-dimensional, we need more of sustained phonation. ADSV, we can do it for sustained phonation as well as connected speech. Motor speech profile has its own protocol like DDK, syllabic rate, and all that. And we can have its own measures for the motor neuron disorders. For fourth one was real-time speech, where we could have pre versus post therapy or live versus copying strategy for the patients, which is again for the therapy. Then we saw voice games, which are again for the therapeutic purposes, especially for children. But I have used it for adults and believe me that adults also love those games. I also love to fire and burst the balloon. Okay, so don't think that these games are only for child. And I have used it for adults and they love it. Okay, even I have given these kind of games for Parkinson's disease, where amplitude was an issue. So with the visuals, they did beautifully with the amplitudes, Parkinson's disease patients, and they were all above 50 and 60-year-olds, so they also enjoyed. So take-home messages like it is a clinically good measure for voice and speech disorders, can be easily used in daily routine practice, because the overall, if you take all the analysis, like suppose a voice patient comes to me, like a patient comes with a complaint of hoarseness since 2 weeks, comes to me. So what will I do first? I'll take the case history. I'll take the perceptual analysis. I'll do the perceptual analysis in the software. I'll do MDVP. I'll do ADSV, and I'll give the report after endoscopy video is shown to me. Okay, so I'll give a comprehensive report of direct visualization. I'll give a comprehensive report in that direct visualization, indirect visualization, that is like the perceptual analysis and the acoustic analysis, along with the patient's feedback of his own severity. For example, I'll take VHI with it, or say, for example, fatigue index. Okay, whatever is the problem with the patient, I will have perceptual analysis, clinician and client. I will have acoustic analysis and recording saved in the computer. I will have a good visual data report of analysis to be given to the patient. And all this can happen in just half an hour. So which is clinically more better for the daily routine practice. And you have given a comprehensive report. So any otolaryngologist or a neurologist sees that report, definitely they're going to send the patient back to you. Okay, or send more patients to your clinic. So that is what is ultimately we want, right? So record keeping and database is paperless. So you don't have to worry about, okay, have I saved this data? Have I given, this report to this patient? So it is all recorded and saved systematically in your system, and even can be printed very easily with your name, center, and address. So I've been, really happy with the way the report turns up at the end. I'm really happy about it. So time saving and cost effective. So many people say that CSL is very costly. Do we really invest in this? So I say, if you really want to practice in voice versus if you want to practice in today's genre. So today's genre is not handwritten reports. Today's genre is more of a digital reports. How much ever, whether you accept or don't accept, the handwritten reports now do not look those professionals or that trendy, I would say. I definitely will be more happy to see a printed report than a handwritten report. So definitely today's genre, you have to live with, you have to go on with it. So you will have to learn and invest for a better future of your clinical practice. So as in the audiology practice, you have audio meter, impedance meter, and all the audio rooms set up. So much of investment, pre-investment. I think if you want to practice voice, definitely you do have to invest a lot. So can be used for online therapy as well. So it was very easy when I did online. And we had CSL. So what we used to do is record, okay, live recording and sending the reports online. We have also tried, like in one of the dissertations, where the patient would say it live and I would have a good quality speaker and the recording was done like that online. And we found that with some corrections to the software, with some correction with the filter setting to the software, we could get near as live input as we could possibly get. But yeah, obviously CSL, as per their guidelines, it is not allowed, but for clinical practice we used to do that. And yeah, so it can be very well used in day-to-day clinical practice. This is my message to you all for taking home today. So signing off, Namita Joshi from Samparki Polyclinic, Pune. Thank you so much for having me.
Thank you very much, ma'am, for your wonderful presentation. It was a wonderful learning experience for all of us. Ma'am, we have one question in the
Yeah.
chat box. It says that DDK includes AMR and SMR. So what is the syllabic rate?
Syllabic rate in a sentence. Okay, so a DDK we are taking as in particular syllables, right? So syllabic rate, average syllabic rate is in a sentence. Like you have to record a sample of connected speech, and then the co-articulatory gaps we call it as. So how much is the syllabic rate in a sentence? It measures average.
Okay, thank you, ma'am. We have one more question from the same person. Is CSL a system that includes VisiPeach, WAGMI, etc.?
It's not WAGMI. Yes, VisiPitch is a software from a CSL. Okay, so there are versions, like, okay, there are versions. So there is a VisiPitch. WAGMI is different. WAGMI is a different company altogether. Okay, CSL does not give WAGMI. CSL gives VisiPitch. Yes.
Okay, thank you very much. To all the participants, are there any more further questions you would like to ask? So, ma'am, I think there are no more questions for today, and I would like to call upon Dr. Indranil Chatterjee, sir, to give you the thank and felicitate you to thank you for attending and providing us this wonderful experience to this webinar. Indranil, sir, are you ready here? Ma'am, just a second. I think sir has some network problem. I'll call
Yes,
upon him.
yes, sure, no issues.
Sorry to say that Indranil sir is not being able to being added right now due to some technical issue. He will announce the next webinar very soon. And
No
we
issues. Thank you.
very,
Thank you so
thank
much
you very
for
much, ma'am.
having
Thank
me.
you very much. Thank you very
Thank you.
much. So we will like to hear on end the meeting from Shai WB today. Thank you everyone for attending and participating. It was a great pleasure.
I have already joined, Namita.
Okay, sir.
So
Okay.
thank you, Namita ji. It was a very marvelous presentation. Actually, it is basically very intended presentations because we have CSL. We have to teach students. Even students have to learn because so many students of our institute they are doing there's master's dissertations on CSL. So so it is a very interesting and very elaborative talks on CSL. Hope in the next time also I will get you to deliver some more lectures on this area.
Sure, sir.
So
Thank you so much.
thank you, Namita madam, and also Auditivo for arranging this particular beautiful webinar. So I conclude ISLP webinar for today, and I just tell you the next ISLP webinar probably will be on vestibular science. I'll just let you inform in the group.
Okay.
Thank
Okay.
you.
Thank
You
you.
all.
Thank you.